A very good morning. This is the second lecture on malaria. Earlier we had spoken about malaria epidemiology, the different types, agent factors, host factors, environmental factors. We discussed the vector. Today we shall discuss the mode of transmission of malaria. Basically, malaria transmission is by three ways. One is by vector transmission, one is by direct transmission, and one is called the congenital malaria. When we talk about vector transmission, you see this vector transmission, basically we have a reservoir of infection that's an infected man. So the infected man is the reservoir of infection. He has the gametocytes, male and female, and these gametocytes are then ingested by the vector, that is the mosquito. In this mosquito, the vector, these gametocytes, what happens is they undergo different type of, they change the form, they change and they even multiply. So the parasites multiply, the parasites also change the form. And that is why we call it cyclopropagative. So the vector is basically the biological transmission. Over here is cyclopropagative. So this vector or the mosquito bites this man or the infected malaria man, then bites another man who's susceptible, who does not have malaria, and transmits or injects the sporozoites, which are the parasites or the parasites of the vector. The direct transmission, basically direct transmission is directly when you're giving a blood transfusion which has got malaria parasites, through needle stick injuries, even in a lot of cases, sharing needles, especially amongst the drug addicts. Congenital malaria is the malaria which a pregnant woman, when she has malaria, she then transfers these parasites to the fetus, and the child suffers from what we call congenital malaria. The next discussion today we'll have is on the life cycle of the malaria parasite. The malaria parasite life cycle involves two hosts. The primary host is the mosquito, which we also call the definitive host, and the secondary host is the human, who we call also the intermediate host. The primary host is the host where the sexual multiplication happens or the sexual life cycle happens, and the intermediate host or the secondary host is where the asexual life cycle of the parasite happens. So what happens is, during a blood meal, a malaria-infected female Anopheles mosquito inoculates sporozoites into the human host. The sporozoites infect liver cells, they mature into schizons. So the transmission is what? The transmission is the malaria bites the man, the vector bites the man. And when the vector or the Anopheles female bites the man, it releases or it injects saliva. In that saliva, there are multitudes of sporozoites. Then these sporozoites enter the bloodstream. And once it enters the bloodstream over here, as you see, it stays in the blood vessel, in the bloodstream for about 30 to 60 minutes and tries to avoid the phagocytosis of the leukocytes, and it invades the liver. It invades the liver, and in the liver, it enters the hepatocyte or the liver cell, and it infects the liver cell. And in this hepatocyte, in the liver cell, two things happen. One is some of these sporozoites or the parasite, they don't undergo replication. What they do is they just lie dormant and they stay as hypnozoite. But the other parasites, they undergo asexual replication or multiplication or nuclear division, as you may call it, and they keep multiplying and multiplying to form a schizont. And over time, over a couple of days, could be 5, 6, 7, 8 days, these schizons then rupture and release a lot of merocytes. Then what happens to these merocytes which are released by the liver cell is that they enter again the blood stream. And in the bloodstream, they now target the RBCs. And once they enter the RBCs, they target the RBCs, they enter the RBCs, and again starts multiplying in the RBC. The initial stage is the immature trophozoite, or the ring stage. But some of these, what happens is, some of the parasites, they don't undergo further replication, they become gametocytes, and male and female gametocytes. And some of these parasites in the RBC, like the ring stage or the immature trophozoite, then becomes a mature trophozoite, then it becomes a schizont and keeps multiplying, and then the cell increases, it ruptures, and the ruptured schizont again releases merozoites, and this cycle keeps continuing. This is called the erythrocytic cycle, and the earlier cycle, the liver stage cycle, was called the exoerythrocytic cycle. Now, after most of these, as I said, the gametocytes, which are in the RBCs, are then now freely flowing in the bloodstream, and when another mosquito comes to take a blood meal, what happens is they take up a lot of blood, and the blood contains these gametocytes. The mosquito takes the blood meal, ingests gametocytes. Once the gametocytes are ingested, the male and the female, the male is the microgametocyte, the female is the macrogametocyte, they fuse to form a zygote. And after some time, the zygote then becomes motile, and that motile zygote is called a ookinete. This ookinete then pierces the midgut wall and forms a cyst. This cyst is the oocyst, and the parasites are multiplying inside, and suddenly, and then the oocyst bursts, and the burst oocyst releases a lot of these sporozoites, which then enters the salivary gland. This mosquito, or this female Anopheles mosquito, which has got sporozoites in the salivary gland, are the infective mosquito. The man, or woman, who has the gametocytes, both male and female, in the blood, is the infective man. Now we shall discuss the clinical aspects. The symptoms of uncomplicated malaria. Most of the symptoms of malaria basically are chill. You have fever with chill and rigor. So there is fever, there is chill, there is rigor. And there are certain stages. The stages are the cold stage, the hot stage, and the sweating stage. The fever is usually accompanied by fever spikes, sudden rise and fall in temperature, chills and rigors, followed by sweating. Some patients also experience bouts of nausea, vomiting, diarrhea, intense headache, restlessness. And the symptoms of severe malaria, basically the symptoms of severe malaria, you get in P. falciparum malaria, and they are high fever. There's a change in behavior, you get convulsions, fits, unconsciousness, drowsiness, inability to walk, sit, speak, or recognize people's identity. There's repeated vomiting, inability to take oral medication, eat or drink, passage of small quantity of urine or no urine or black urine, severe diarrhea and dehydration, sudden weight loss, loose skin, sunken eyes and dry mouth, and easy fatigue due to anemia. So basically in severe malaria, you have the CNS symptoms, the cerebral malaria, where there is unconsciousness, loss of consciousness, an arousable coma. You may have features of disorientation. Then it may affect the kidney, when the renal system, so there is oliguria, the creatinine, serum creatinine goes high. Then it can affect the different organs, and It may cause hypoglycemia, hemoglobinuria. So there are different types of signs when in a case of severe malaria. The diagnosis of malaria. The clinical method is one, based on signs and symptoms. Then there is microscopy, that is detection of parasites, and rapid diagnostic test or antigen detection. Clinical methods, signs and symptoms are generally, we do not diagnose malaria based on signs and symptoms totally. It has to be a confirmed case, which we shall discuss later. So what are the malaria rapid diagnostic tests? Earlier we used to have only malaria rapid diagnostic test for PF, P falciparum antigen test. Now we have dual, that means P falciparum as well as P vivax antigen tests. Malaria RDTs detect specific antigens or proteins produced by malaria parasites that are present in the blood of infected individuals. They are an alternative to diagnosis based on clinic grounds or microscopy. Some RDTs can detect only one species, P falciparum. Some can also detect other species, P vivax. Blood for the test is commonly obtained from a finger prick. This is a malaria dipstick test. This is a kit. So the test procedure is you bring to room temperature the kit, take a dipstick, label it, take 1 drop of blood from the finger prick or tube and cover the sample pad. Put 4 drops of reagent into test tube. Place dipstick in tube with arrows downwards. Read after 15 minutes. Here it is. This is the pad where you have put 1 drop of blood. Then you insert it into this tube which has the reagent where the arrows are downwards. And then it is read after about 10 to 15 minutes. And then accordingly, if there are 2 arrows or 2 marks, 2 lines, etc., your diagnosis of the different species of malaria is done. Microscopy, basically what we do in microscopy is we take a drop of blood and make it into a thick smear and a thin smear in the same slide. We label the slide and make a thin smear and a thick smear. This is the thick and this is the thin. The thick gives you an idea because the quantity of blood is very high, very more. So you can get what is called, you can see the parasite. But to differentiate the parasite, whether it is a PV or a PF malaria parasite or a POVLA or P malaria, you go for a thin slide. This is the one. Now comes to the guidelines for the treatment of malaria. The WHO guidelines are, WHO recommends parasitological confirmation of diagnosis. That is either by microscopy or by RDT before treatment. But who are the exceptions? The exceptions are children under 5 years of age from areas of high transmission where treatment is based on clinical diagnosis. You see, in very high transmission zones, in inaccessible, very remote places where there is no chance of getting your blood tested by RDT or microscopy, that's the place where you have to rely on clinical signs and symptoms. And suspected severe malaria where parasitological confirmation is not immediately possible, those are the only 2 exceptions where we can give anti-malarial treatment. The National Drug Policy 2013, Government of India, was done by the National Vector-Borne Disease Control Program. The effective treatment of malaria under the National Drug Policy aims at providing complete cure of malaria cases, number 1. Number 2 is prevention of progression of the uncomplicated malaria into severe malaria. You are trying to prevent uncomplicated malaria getting into severe malaria. How do you do it? Early diagnosis and complete treatment. 3. Prevention of relapses by administration of radical treatment. The relapses, where do you get? You get the relapses in P vivax malaria. So administration of radical treatment. What is the radical treatment administration? By giving primaquine. For how many days? 14 days. In which malaria? P vivax malaria. Interruption of transmission of malaria by use of gametocidal drugs. Like in P falciparum malaria, primaquine is given as a gametocidal drug to prevent interruption of transmission. And prevention, Preventing development of drug resistance by rational treatment of malaria cases. This is very, very important. You see as now, PF chloroquine drug resistance is there. So that is the reason why we don't give chloroquine to Plasmodium falciparum cases. Why? Because over the years, so much of irrational treatment was being done with the chloroquine. So the parasite, the PF, has now grown resistance to chloroquine. Treatment of vivax malaria. Treatment of vivax malaria. Now let us talk of an area, let us talk in terms of a rural area where an endemic area for malaria, where patient comes, there are a lot of patients who have fever. So when a patient has fever without other symptoms like cough, without other symptoms like burning micturition or by some skin lesion, we suspect it to be a case of malaria. So these malaria cases, can we give treatment? No. Treatment cannot be given unless and until you prove by parasite detection either through the RDT or by microscopy. The presumptive treatment which was earlier done, presuming that the fever was due to malaria and giving 1 dose of chloroquine, that has been banned. So what do? In a case, we send the person for an RDT or blood microscopy, a smear test, to see the type of parasites in the blood. If it is a case of P. vivax malaria, Plasmodium vivax malaria, what do? We give a course of chloroquine for how many days? 3 days. And what do? We give a course of primaquine. For how many days? 14 days. Why do we give chloroquine? We give chloroquine because it is a blood schizonticidial drug. It kills the parasite in the erythrocytic cycle. And why do we give the primaquine? The primaquine is given to prevent the relapse because it acts on the hypnocytes. So then you can prevent relapse of P. vivax malaria. But the only problem is when you're giving primaquine not given to pregnant women, primaquine is not given to infants, and primaquine is also not given to individuals with G6PD deficiency. But now in a BPHC, we don't have the status. Let us talk in terms of G6PD deficiency. Pregnant woman 5, we will not give primaquine. Infant below 12 months, we will not give primaquine. But how do we assess whether the patient has got G6PD deficiency or not? You cannot assess it in a BPHC level, in a block primary health center level. It can only be assessed in a large hospital where they've got those tests to detect it. So what do? What we can do is see whether the patient has anemia or not. How do you do it? You do a hemoglobin estimation. If the patient has got anemia, we will not give primaquine. If the patient does not have anemia, we will give primaquine under supervision, and we will inform about the warning signs of primaquine, of G6PD deficiency. That is, in case the urine becomes dark colored, or in case the person starts getting cyanosis. Then what do? We tell the person, do not have the drug. You have to then we refer the patient to the medical officer of the PHC or the block primary health center or to any doctor. So the drug schedule for P. vivax malaria is, as I said earlier, it's a 3-day course. What is the total dosage? The total dosage is 25 milligrams kg body weight for the entire 3 days duration. What we do is basically we break it up into day 1, day 2, day 3. On day 1 we give 10 milligram per kg body weight. On day 2 we give 10 milligram per kg body weight. And on day 3 we give 5 milligram per kg body weight. Primaquine. Primaquine is given at the dose of 0.25 milligram per kg body weight. For how many days? For 14 days. So day 1, day 2, day 3 we give chloroquine, 10 mg kg body weight, day 1, 10 mg per kg body weight, day 2, 5 mg per kg body weight, day 3. And day 1 to day 14 we give primaquine. This is, mind you, an adult dose. And what is the dosage of primaquine we are giving? We are giving it at 0.25 milligram per kg body weight for 14 days. So basically, as we said earlier, 10 mg per kg day 1, 10 mg per kg day 2, 5 mg per kg body weight day 3. A chloroquine 250 mg tablet is having about 150 mg base. So 150 mg base means you're giving 4 tabs adult dose, 4 tabs adult dose, 2 tabs of chloroquine adult dose. These are all adult. Chloroquine is never given on empty stomach. Always give chloroquine after food. The primaquine is available in 2.5 and 7.5 milligram tabs. So we are giving primaquine at 0.25 mg kg body weight daily for 14 days. That is about adult dose 15 milligram per day into 14 days. So if you are giving a 7.5 milligram tablet, we are giving 2 tablets daily for 14 days. This is the treatment for P. vivax malaria. The treatment of uncomplicated falciparum malaria. Remember one thing, earlier days we used to give in falciparum malaria chloroquine also, but there has been a total resistance or very high resistance to chloroquine to PF parasites. So chloroquine is absolutely banned in a case of PF malaria treatment. So what is the treatment we are giving? We are now recommending, or the WHO recommends, our National Drug Policy recommends, artemether-lumefantrine. These are artemisinin compounds, artemether, and artesunate SP combination or sulfur dioxide pyrimethamine combination. The efficacy of the ACTs actually depends upon the partner drug. What is the partner medicine? This is the partner medicine of artemether, and this is the partner medicine of artesunate. Treatment of uncomplicated falciparum malaria. Artemisinin-based combination therapies, ACT, are the treatments recommended for all cases of uncomplicated P. falciparum malaria, including you can give ACT in infants, you can give ACT in people living with HIV/AIDS, you can give ACT for community-based management of malaria, and you can also give ACT for pregnant women, but in the 2nd and 3rd trimesters only. You do not give ACT or artemisinin combination therapy in the 1st trimester. Exception. In the 1st trimester of pregnancy, only use when there is no alternative effective antimalarials. By and large, generally, in the 1st trimester of pregnancy, in a case of malaria in pregnancy, in a case of PF malaria, we give in the 1st trimester tablet quinine, because that is the only one which can be given to pregnant women. Drug schedule P. falciparum malaria uncomplicated adult. Remember what we have done is, in India, the drug policy has done states other than northeast states and northeast states. The treatment regime for uncomplicated P. falciparum malaria is different. States other than northeast states. What are the states other than northeast states? West Bengal, Orissa, Jharkhand, Andhra, Tamil Nadu. So all the states which are outside the northeast states, those are the states. So what is the line of treatment over there? We are giving a combination of artesunate, sulfadoxime pyrimethamine, and primaquine. So basically 3 drugs: artesunate, sulfadoxime pyrimethamine, and primaquine. What is the dose? Artesunate we give 4 milligram per kg body weight daily for 3 days. This artesunate has got, basically you get artesunate in tablets of 50 mg tablet. So how many will it be for an adult? 4 tablets. Sulfadoxime pyrimethamine, the tablet is sulfadoxime 500 mg. The pyrimethamine is 25 mg. This is the tablet formulation. So you will give on day 1 how many tablets? 3 tablets. And primaquine, the dose is 0.75 milligram per kg body weight on day 2. Why is primaquine given in a case of P. falciparum malaria? As a gametocidal drug, it prevents interruption or of transmission of the malaria. In the northeastern states, we are giving artemether 20 mg and lumefantrine 120 mg. It's a co-formulated drug, and we are giving at what dose? We are giving 4 tablets daily for 3 days. And we are also giving primaquine at 0.75 milligram as a 1 dose on day 2. So primaquine is given on day 2. Now, drug schedule for P. falciparum malaria uncomplicated in pregnancy. In the first trimester, we will give quinine, 10 mg per kg body weight, 3 times daily for 7 days. And in the second and third trimester, we will give ACT. And what is the ACT we give? States other than northeastern states, we are giving artesunate with sulfadoxine paramethamine. And in the northeastern states, we are giving artemether with lumefantrine. Remember, in pregnancy, primaquine is absolutely contraindicated. Remember, in pregnancy in the first trimester, ACT is contraindicated, and that is why we give quinine. But in the second and third trimester, we can safely give ACT, that is artemisinin combination therapy. Treatment of severe falciparum malaria. Any of the following antimalarial medicines are recommended. You can give artesunate intravenous or intramuscular, artemether intramuscular, arteether intramuscular, or for that matter, even quinine as a IV or intramuscular. But remember one thing, the full course of ACT or quinine, when patient can tolerate oral medication, that means the patient becomes a bit okay after say 2 days or say 3 days, after taking parenteral, artesunate or arteether or say quinine, then the patient must take the full course of the ACT or quinine. Suppose you have given quinine for say 2 days, then after that, patient recovers after 2 days, after giving, not recovers, but the patient now can eat or can drink water, can swallow tablets, then you will give quinine in the oral form as tablets, and that will be for a period of 7 days. Artemisinin compounds rapid schizonticidial drug for severe malaria. Arteether, trade name is email injection, 150 mg daily for 3 days, deep IM. Artemether is 180 milligrams IM BD, that is twice daily for 3 days. Or artesunate, 2.4 milligram first dose, then 1.2 milligram per kg body weight, 12 hourly, then daily for 3 to 4 days. These are the artemisinin compounds for treatment of severe malaria, severe falciparum malaria. Severe malaria treatment, quinine therapy. Parenteral therapy is a must as rapid parasitical action is warranted. We normally give a loading dose of 20 mg per kg body weight on admission, IV infusion with dextrose or dextrose saline, followed by 10 mg per kg body weight over 4 hours, every 8 hourly in DNS, dextrose normal saline or dextrose. If therapy has to continue beyond 2 days, reduce the dose to 2/3. So how can malaria cases and deaths be reduced? The goal of most current national programs and most malaria activities is to reduce the number of malaria-related cases and deaths. To reduce malaria transmission to a level where it is no longer a public health problem is the goal of what is called malaria control. Control of malaria differs from elimination or eradication of malaria. Elimination is local or regional in scope, very local, regional. Eradication is global elimination. Eradication is not achieved until malaria is completely gone from the world. Malaria control activities having significant developments. 1953 was the launching of the National Malaria Control Program. In 1953, there were nearly 75 million cases, and the estimated deaths due to malaria was 0.8 million. or in other words, 8 lakh malaria deaths. Today we are having only 96 deaths. In 1953, the number of cases of malaria was 75 million. So after this, what we did is, the strategy over here was more on the vector management, that is IRS, insecticide residual spray with DDT. The cases came down. Then they started a national malaria eradication program in 1958. The cases were reduced to 0.1 million or 1 lakh. From 75 million cases in 1953, the number of cases became just 1 lakh in 1966. But in 1970s, there was a resurgence of malaria. This resurgence of malaria was due to a lot of reasons, technical reasons, operational reasons. There were resistance to parasites, to the drug, to less of manpower, poor surveillance. So there were a lot of technical reasons, a lot of operational reasons, management reasons. This is an important one. 2004 introduction of ACT for PF cases only in drug-resistant areas. ACT in 2004 was only given to selected pockets of at primary and central level where there was drug-resistant, chloroquine-resistant PF malaria. Only in those pockets ACTs were given. 2013, the National Drug Policy on Malaria is totally different. PF cases anywhere in India, we are giving only ACT. Chloroquine is totally banned. We do not give chloroquine for PF malaria. There are certain epidemiological parameters which we must know. Number one, these are all based on a lot of the surveillance machinery, and one of them is the annual blood examination rate, ABER. Normally, when we talk in terms of annual blood examination rate, the number of fever cases, 10% of the population have fever per year. We assume that all these fever cases could be a case of suspected malaria. So in a case of suspected malaria, what do? As I talked earlier, is we do an RDT or we make a blood smear. We take a drop of blood, we do a blood smear and to see whether the person has got malaria or not. So 10% of the population has fever. So the entire 10% should be examined for malaria either by RDT or by microscopy. So that is called the annual blood examination rate. So it should be 10%. Should be 10% or more than 10%. Let us say there is a village having a population, a village having a population of 1,000. So in 1,000 village population, 10% fever cases will be 100. So 100 of the 1,000 population must have their blood slides examined every year. That gives you the annual blood examination rate. The API, the annual parasite incidence, is the total positive slides divided by the total population into 1,000. Say for example, if there were 5 cases in a village, 5 cases in a village which has a population of 1,000, so the multiplying factor is 1,000. So what will be the API? API will be 5. SPR, the total positive slides divided by the total slides examined into 100. So let us assume out of say 5 slides, so MP positive were 5. Total slides examined were 100. So what will be the SPR? SPR will be 5. SFR will be the falciparum rate. Total PF positive slides divided by total slides into 100. And PF percentage is the total PF cases divided by total cases into 100. So when we talk in terms of API, what is the significance? It gives you the significance is the malaria situation. This particular area has an API of 2. This particular area has an API of 0.3. So what are your priorities as far as the control is concerned? Your control should shift and focus more to the area where the API is higher. So your control strategies will be the different strategies: early diagnosis, complete treatment, your vector control strategies, your giving of the LLINs, long-lasting insecticide net, giving ITBNs, insecticide-treated bed net. So all these different strategies which we have for the malaria control program are more than that area which has got more API should get more focus, both in terms of treatment, even in terms of vector management, of which insecticide residual spray, the DDT spray, or the malathion spray, or the pyrethroid spray is very, very important, and a lot of net distribution is given. These nets are basically insecticide-treated bed nets. Surveillance. When we talk in terms of surveillance, remember we just discussed about the ABER, the annual blood examination rate. The annual blood examination rate depends a lot on surveillance. Now, surveillance is of two types. One is the epidemiological surveillance and one is the entomological surveillance. In epidemiological surveillance, the surveillance is for fever cases and preparation of slides. Active surveillance and passive surveillance. So when we talk in terms of surveillance, active surveillance, what is active surveillance? When my health worker goes house to house in the village asking for people who have suffered from anemia in the last 14 days. If they have suffered from malaria, he does a RDT, does a test, draws a blood slide, and sends it. So he's picking up the cases. And the passive surveillance is when the patients who are suffering from fever go to the health center or to the sub-center. Entomological surveillance is when we are doing vector bionomics, a study which are done by entomologists, basically done by insect collector who collects the insect and then sends it for dissection of the salivary gland, dissection and identification of the vector. It could be a culicifacies, Stevens eye, etc. And that is the entomological surveillance. Thank you for the day. Thank you very much.